And so you guys can also come back and watch this later. Okay. Okay. So let me share my pad and we're gonna do it on this one instead. Because it's better on my pad than it is on there. Okay. So this first question, the answer was foramen spinosum. Basically, what they're getting at, right, is they're wanting you to figure out what vessel is damaged and then where that vessel is coming from. Now, if you have any questions, I can't see the chat now because I'm sharing my screen on my thing. Just go ahead and unmute yourself and just ask the question as we go. And you can interrupt me however you want to do it. I don't have any big rules or anything like that. Just be kind to your fellow students because we're all in this together, right? Um, so so with that being said, that's kind of what they're getting at is this pterion here is where the frontal bone, the parietal bone all fuse together. And always at this location, you have that middle meningeal artery here. That's get damaged. Okay. And as a result, you end up getting what type of hematoma? Do you guys remember? You can just unmute yourself and tell me. There's only 22 of us at max. Is it a subdural? Is it epidural? Is it a subarachnoid?
Epidural?
Yeah, perfect. You can get an epidural.
Epidural.
Yeah, great. Epidural hematoma. Good. So now with that being said, there's a variety of things that go through these openings. Okay. And I have this picture here. You have access to these PowerPoints. I'll send them to you. You have access to the recording. I'll send that to you as well. So you don't really have to worry about sitting down and taking notes. Just pay attention and follow along and do more recall than anything. Okay. So here on the right is where you have all the corresponding things that leave and enter. Okay. So I'm going to highlight the main ones that you should make sure you remember. The medial meningeal artery is a biggie. You have to remember where that comes in and goes. Okay. As well as cranial nerve 5. Because cranial nerve 5 goes through multiple openings and they love that. They love it because people miss it. Okay. If people miss it, they love to ask it. Okay. So with that being said, there's a way that you can remember. Okay. I have used this mnemonic. You can use it too if you want to. Standing room only sorry. And when you look at rotundum, right? This is for 3. No, yeah, V3. Okay. And it kind of looks like only 3. Okay. And then above that is always 2 and then 1. Okay. So 2 will always go in rotundum. 1 will always go into standing. Okay. Now, and then sorry is where you have the middle meningeal. So that, in all honesty, is comprising all the important ones that you should know moving forward. Now with that being said, does that mean you don't have to worry about all the other cranial nerves? No, you do have to remember the cranial nerves, because those could pop up, but these are the ones that are more common to pop up. Okay. Let's see. What else is also very important to remember moving forward? That's about it with this. Okay. And then I threw this in here just because some people love to read. Okay. If you love reading, you can read it. If you love looking at a diagram, you can just look at the diagram. Okay. Because I covered the exact same thing, nothing really different. Now, for here, the second question, it was talking about the polymerase chain reaction, PCR. Okay. And in PCR, essentially what you're doing is you're amplifying DNA. Okay. So with that being said, what is required for you to be able to amplify DNA? Can anyone tell me? It's always required.
Repeat it again.
So what is required for you to amplify DNA or undergo replication?
to denature it.
Okay, yes, you have to denature it. What else? What else is very important to have for RNA or for DNA polymerase to work? If you
You
don't
said an
have this,
RNA?
so a primer, right? And it is RNA, so great. It is RNA. And it's a primer. Okay. And that's exactly what this here is hinting at. The initial sequence of the 3' end of a DNA strand. It's hinting at this idea of a primer. Okay. Because we grow from a 5' to 3' direction, right? But we read in a 3' to 5' direction, which is why it's placed at the 3' because we're reading this first. Okay. Does that make sense? Yeah. Okay.
Yes.
Great. So now, with that being said, what are the important things with this guy? This is a whole hullabaloo stuff, right? There's a lot of stuff that goes in with with the replication of DNA. The big thing you need to make sure that you walk away with is this idea of 3', 5' is reading, 5', 3' is growing. You need to make sure you remember that, okay? Because any question that has to do with this is going to be hinting at this aspect because this is the most important thing, okay? Now, outside of that, as we go further away from our bullseye, right? Here's a center must know. As we go further away from the bullseye, what else do we need to make sure we know? We need to make sure that we know that the DNA strand is making is complementary to the template strand. Okay. So for instance, you get A to T's, G to C's, right? So that's the other thing that's very important when it comes to this DNA replication. Okay. Now, we already talked about the RNA primer because that hints at this concept here. Okay. All right. Good. Any other questions on that? No. Okay, let's move on. So once again, here's a reading of it. Okay, for this one, what they're getting at here is they're asking you what is the needle passing through? Okay, as it goes through these layers, what is the needle passing through? Okay, and for you to know that, it's literally just an anatomy aspect of what is the layers inside the spinal cord. Okay, which ends up being ligamentum flavum. Okay. Now, when we look at this, there's two different separations. There's outside the vertebral column and there's inside the vertebral column. This is very important because they could switch the question. And instead of saying, what is the layer after the epidural space? They could, or what's the layer before you enter the epidural space? They could have asked you, okay, what's the layer before you enter the spinal canal? Okay, or what was punctured before you enter the spinal canal. And that's this interspinous ligament. Okay, so these two here are very important. Okay, because those are the two that's surrounded around entering the spinal or vertebral canal. Okay, and you can see this one here, let me use a different color. This one here is corresponding to the interspinous. And then this one here is according to the ligamentum flavum. Oh, that's a bad color right there. We'll do it here. Okay. Any questions on any of that? No? Okay, here, let me just make sure, see the chat. Oh, so there are two people. So I guess I cannot. We'll figure something different out as we move forward. Okay, great. All right, let's continue. All right, now we've talked about that one. This one is also a very important concept because this is getting at your behavioral science. Okay. Now, in behavioral sciences, there's only a few big things you need to make sure you understand. One of them is classical conditioning. The other one is reinforcement. You have to be able to understand when one is conditioning and when one is reinforcement, which is what this question was getting at. Okay. So, what we have here in the vignette is we have someone where they did an experiment, right? And they gave them a tangerine after doing the experiment with the addition of a song. Okay. So this is a stimulus plus a non-conditioned stimulus. The pop song is a non-conditioned stimulus. The tangerine is the intangible stimulus. When you give someone a tangerine, they're automatically going to feel hungry. You don't have to teach them to be hungry when you see a tangerine, right? So that's known as the stimulus or the non or the the stimulus, okay? So as we move forward, you end up finding out that the audio clip starts to then cause the same presentation as if they were presented with the tangerine, okay? Now, when you do that, this is now known as the conditioned stimulus, okay? Whenever the stimulus by themselves is able to elicit the same response that the tangerine did. Okay. So that's why this is known as classical conditioning. Now, with that being said, we went over this, right? This is the unconditioned stimulus. You're exposing them, right? And then it becomes a conditioned stimulus, with the light now being the thing that causes it. Okay, with a conditioned response. Now, this is hinting at reinforcement, positive and negative reinforcement. When you look at positive and negative reinforcement, you got to break it down into a two-parter. Okay? The first part, you need to discern, is something given? And the second part, you have to discern, is there an increase or a decrease in behavior? So, for example, if I was to say, a patient shows up and they're complaining about how their child is screaming whenever they have to leave the house. Okay. So what the parents end up doing is they start to punish the child for or disciplining the child because of them screaming out, right? And this increases the behavior, and then child ends up doing more, right? So you have to break that down into two-parter to find out if this is positive reinforcement or negative reinforcement. So we're giving something to them. Okay. We're giving them a punishment. We're punishing them. Okay. So automatically, when you add something, you automatically go to this aspect, okay, of it being here, punishment. Okay. So we have this aspect where something is added and here something is taken away. Okay. When something is added, you're undergoing a punishment. Okay. Now, the next thing you have to then go about doing is if the behavior is increased, or decreased. Okay. If the increase is if the patient then starts to increase behavior, that's a positive. Okay. However, if the patient starts to lose behavior, then we're thinking of it being more of a negative. Okay. So that's what's going on in this box here. Does anyone have any questions about that as we move forward? Yes, no, maybe so. Okay. I don't see anything in chat, so we're going to keep moving on. Perfect. Cancel that. Okay. All right, let's keep moving on. So that's why this is classical conditioning, what we discussed. Now, this one here, we're looking at the corresponding header kind of like tree, right? And we're trying to determine what is the probability of this patient here, which is a question mark, right? So whenever you want to come across these questions, you first have to detect or depict what type of genetic disorder this is. If this is autosomal recessive, is this X-linked recessive? Is it X dominant? Is it autosomal dominant? Which one is it? Looking at this, is it mitochondrial? Which one do you think this is? Okay. So this scenario is an X-linked recessive condition. Okay. But with that, because you got males here, right? And they're trying to find out if this male here would be involved. But this male here was never, this one's a normal male. And the females are not affected. They're carriers. Okay. If it was X dominant, the females would be presenters, not carriers. Okay. So that's why this is X recessive and not X dominant. Okay. Now, from that, we have to discern, well, what's the possibility that this patient here got the disorder, right? So if you do your Punnett square, the patient ends up being a 50% chance of getting the actual chromosome, right? Because here's the little X, here's the big X. So she has a 50% chance of getting the affected chromosome. Okay. As well as here with this child, 50% chance of getting the affected chromosome. So as a result, it's 50 times 50, which equals 25%. Okay. So that's how you ended up with that answer. Is there any questions about that? And the reason why you have to do that is because you don't know if this person is a carrier or if they are actually have the disease. Since you do not know, you have to include them. Okay. If we knew that she was a carrier, then it would just be 50%. Okay. All right. So once again, 25. All right. Now, here is a question that's a little bit harder to grasp, right? So here it's talking about someone who's exercising. And as you're exercising, it's asking, well, what's happening? Okay. So in our lung, we got different zones, right? We got zone 1, zone 2, and zone 3. Now, my question is this. Where in the lung, zone 1, zone 2, and zone 3, do we have the highest oxygen? I heard somebody. Does it click? Perfect. Zone 1. Great, great. Well, so let's talk this through because it's not zone 1. It's zone 3. I thought I worded it a different way. So here, let me show you. Whenever you have oxygen, remember oxygen always travels down to the lowest. Now, this has the highest amount of oxygen supply and the highest amount of blood supply, which you guys are thinking of is this thing known as the VQ ratio. That's why you said zone 1. Zone 1 has the lowest oxygen and the lowest blood supply. Okay. However, the ratio of oxygen to blood supply is greater, which is why you end up with a number like 3 with the VQ, but a number like 0.6 in zone 3. Okay, because you got more blood supply going to zone 3 than in zone 1. Because it's the same concept. When your heart pumps blood, it's going to follow the same thing, gravity. So the blood pools in zone 3. So zone 3 has the highest blood and the highest oxygen. But the ratio is they got more blood than oxygen. Okay? Now, that's all good and well with understanding the general concept. Now, my question to you now is, if we start running and our blood pressure increases, what is going to happen to the blood supply to the lung? Yes, oxygen diffuses downward. Correct. Great. Yes, it increases. It increases. Exactly. So whenever you have an increase in blood supply, you got to think of it like this. You're taking these blood vessels, right, with, let's say, 100 BP, and you have the alveolar pressure pushing on the blood vessel, let's say at 110 pressure. So as a result, the blood capillary gets constricted because you get more pressure from the alveoli pushing on the blood vessel, right? So since you got more air pushing on the blood vessel, you have less perfusion than ventilation, okay? Which is why the VQ ratio is high. Now, when you start running and your blood pressure increases to, let's say, 120, you're now able to expand those blood vessels because the pressure in the lung is still 110. So now you're able to expand those blood vessels and more blood can travel through it and you increase perfusion. And as a result, the VQ ratio decreases. Now, when you have a high ventilation, with low perfusion, what is this called? Dead space. To be more precise, is known as physiological dead space. Okay? These are areas where air is located at, but there's no perfusion happening to pull that oxygen out. So that's why it's called dead space. Okay? So when you start increasing perfusion and the VQ goes down, your physiological dead space also goes down because now those areas that didn't get blood are now getting blood. So then the ventilation matches the perfusion. And that's exactly what happens when you exercise. Okay? So you end up here, right? This is you normally. Okay? And then at the apex, it's more around here, right? You have more ventilation than you do perfusion. So as a result, the CO2 is lower because CO2 is coming from the blood, right? Oxygen is coming from the air. So that's why it's higher. You don't have any blood to take the oxygen. And you end up pulling it towards this way when you run and you exercise. Okay? Any questions about that? Pretty good? All right, great, 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 great. I'm very happy because that's a very complex concept to understand, right? Perfect. So now my question I want to ask you now, right? Let's say we have someone who is running. He's running, right? And then he stops and relaxes. What's happening to his what's which one of these? Oh no, I won't do that. So what is happening to his alveolar dead space? What's happening? He's running and then he stops and relaxes. And now it's asking you, what is his alveolar dead space? Yes, perfect. Perfect. Yes, it starts to increase back again because of, once again, the perfusion decreases, and then you start increasing your alveolar dead space again. Great. I love it. Yes, a decrease in the perfusion. Great, great, great. Okay, so good, 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 good. Now, that's exactly what's going on here. Now, here in this question, what ultimately they're saying is this person had damage. He fell, trauma, right? And when they look at his actual peritoneal cavity, there's no collection of fluid, but he's bleeding out. Okay, because his hemoglobin is low. So he's bleeding out, but it's not in the intraperitoneal cavity. If it's, excuse me, if it's not in the intraperitoneal cavity, where else could it be? Inside the abdominal cavity. This is where it could be retroperitoneal. One of the organs, retroperitoneal, have been damaged instead, and as a result, they're bleeding out of one of those guys, and it's not presenting inside the intraperitoneal cavity. Okay, so for instance, they could have said something differently, like they looked in the pouch of Douglas and there was no fluid in the pouch of Douglas, right? That's also somewhere where that fluid collects if it's in the intraperitoneal cavity, right? Is that pouch of Douglas. Now, from there, all you got to do is know which one of these is intra or retroperitoneal. So the kidneys is a big answer here. The way I do it, because I'll be honest, remembering all those little small organs is hard. It's really hard to remember all the little small organs inside. If the intraperitoneal, is it retroperitoneal? Is it secondary retroperitoneal? Like, what the heck is going on here? The big thing is if it's closer to the back of the abdominal wall, it's retroperitoneal. Okay? Think of it. Aorta is attached to the back of the wall, retroperitoneal. Okay? As well as the ureters. So that's a good way I remember it. And then if it's inside the cavity floating around, more than likely it's intraperitoneal. Okay. Now, there are some exceptions to that rule, of course, where you have things like the first duodenum being intraperitoneal, but the remaining portions being retroperitoneal. Okay. So there are some exceptions to that, or the idea that the pancreas, except for the tail, is retroperitoneal. Okay. And then when you look at the actual colon, the ascending and descending colon is retroperitoneal, but the transverse colon is intraperitoneal. So as long as you know the exceptions, everything else is easy. Okay. Spleen is not snug against the back wall, which is why it's intraperitoneal. Okay. Any questions on that? Yes, there is a mnemonic, sad puckers, that you can go off to. I don't mind mnemonics. I just have a hard time remembering what each letter means in a mnemonic, which is great if you can, but I just have the issue of not being able to know. Okay. So I make things a little easier on just visual spatial things. All right. But yeah, sad pucker is a great mnemonic as well. Okay. Let's continue. Now, here, this is a biochem question. Okay. So you guys just had your biochem review. So I hope you did well on this one. But ultimately what it's asking you is what's most likely to be increased, right? Whenever you do questions, reword it first. Reword the question. I can tell you, I've reworded every single question I've ran across via NBME, via like MBOS, via UWorld, via the Socrative questions that I get. I reword every question. Now, when I say reword every question, I don't want you to reword everything. Just reword what the heck this bottom statement is saying to you. Which of the following metabolites is most likely to be increased in this patient? So my reword would be this diagnosis that this patient has, it causes what to be higher? Okay, well, now I have a goal. What is the diagnosis? And then after I know the diagnosis, I can then depict what's going to be higher, right? So when you read this, you see cataracts. Whenever you see cataracts and it's talking about a biochem thing, there's only a handful of things that do that. One is galactose metabolism. Okay. And the second is if you are diabetic. Now, outside of those things, it's very hard to find bilateral cataracts or cataracts in general from a biochem perspective. Fructose doesn't cause cataracts. It's more galactose metabolism. Okay. So which of the following is the guy? So now with that being said, there's different diagnoses. You could be classic galactosemia. It could be due to galactokinase enzyme. So we don't know. But when you read the vignette, his liver is big. He has jaundice. There's only one galactose metabolism that causes phosphates or more or less metabolites to build up because they can't be used. Right? In galactokinase deficiency, you have galactose not being able to even enter the cell because it enters the cell and it never gets phosphorylated. So then it just leaves. But in classical galactosemia, you actually get buildup, which is what this is hinting at. Classic galactosuria. Now, here is galactokinase deficiency. Okay. And just like I was saying, you don't build up galactose because the main thing that keeps sugar inside of the cell is what? What is the main thing that keeps sugar in the cell? What is the main action that keeps sugar in the cell? So you're telling me enzymes.
Recording in progress.
So be more big picture. Be more big picture. You got to think big picture here. Because if you think in big picture ideas, you can apply it to smaller details. Phosphorylation. You phosphorylate anything, it's not leaving the cell. Okay? Because that phosphorylated group bloop, prevents it from being able to transverse that membrane. Okay? So that's why phosphorylation happens with glucokinase or galactokinase or with fructokinase, any of those guys, right? They're a kinase, so they add on a phosphate group to trap them inside the cell. Now, if you don't trap them in the cell, then you won't get it stuck in the liver. So the liver doesn't get affected. However, if you affect the second enzyme, which is, I'm sorry, it's just pure memorization. You got to memorize these enzymes. But the actual symptoms you can understand though. Now, if you trap it inside the liver, you're going to damage the liver, which is exactly what happens. You get liver damage, you get lethargy, you get vomiting, diarrhea, all these things because you're trapping these sugars inside the liver and they can't leave. Okay? Perfect. Now, they all present with cataracts because of this enzyme reaction here. They all go to the lens, and then from the lens, they get aldose reductase into galactitol, which then ultimately becomes fructose. And remember when I told you, you do not get cataracts from fructose? This is why. Because fructose is the end metabolite anyways. If fructose goes to the lens, it's not going to all of a sudden become something different, right? It's this buildup that causes cataracts, not the fructose. That's why in any of the fructose conditions with biochem, you do not get cataracts. Does that make sense? Okay, perfect. Good, good, good. And that's a key hint. Whenever you're reading questions that are biochem, right? That's a very big key hint. If you see that there's cataracts, it cannot be a fructose thing. It has to be galactose or diabetes. And diabetes is very slim for you to guys see anyways right now. Is going to be more towards the aspect of galactose or maybe a false unitization of glucose. Okay. Perfect. Now, this is that I just have it down here for you to see. It's all collectively put together, but you saw it up above. So galactose 1-phosphate. Now, here is a question that you guys went over with EndoRepro, right? This is something you guys just went over in your courses. So here is a scenario where they want you to just tell us what the hormone is, right? So this hormone has this presentation. What is it? Okay, that's essentially what this is asking. So causes FSH and LH, excuse me, to decline, but then increases it later. There's only one hormone that does that, and that's estrogen. Okay. Now, with that being said, let's talk a little bit about estrogen and why it does that. Okay. So you have these secondary follicles. You got tons of them. Okay. They're all competing to be the best one. It's like gladiators. Okay. They're all competing to be the best one. Now, these follicles don't have swords and weapons, right? So instead, what they do is they increase the level and expression of corresponding receptors, FSH and LH. Okay? They increase expression of these guys, of these receptors. And as a result, as the levels of LH and FSH decrease, okay, before the spike, as they start to decrease before the spike, the weak ones that have not had enough LH and FSH to stay stimulated die off. And only the big guys that have a lot of FSH and LH receptors stay. Does that make sense? Okay. So what ends up happening is your follicles, right? They're competing to be number one because you can only ovulate one of these follicles, right? So what happens is when they're growing through this growing cycle, right, before your actual menses, these guys are increasing their LH and FSH receptors. Okay? They're increasing them. So as you increase LH and FSH receptors, if you have 5 molecules of LH versus 100 molecules of LH, do you think something that has 5 receptors? So let's say 5 receptors versus 10 receptors, because I'm gonna explain this out better. So 100 and 5 or 10 receptors. Do you think they both get activated? And 5 and 10 receptors. Well, yeah, because there's a lot of it. There's 100 of them. So at the very beginning, they're both getting activated at the same rate. Okay? At the very beginning, they're both getting activated at the same rate. But as LH decreases and is now 5 molecules of LH, the 5 receptors are very hard to find those 5 LH molecules. But if you got 10 receptors, you have a higher possibility of hitting those LH molecules. It's almost like you're taking shots for basketball. If you have 10 balls, more likely you're going to score one of those 10 balls versus someone who has 5 balls. Okay? So these guys end up finding the LH molecules and they stay activated, while these guys end up not finding it and they die. Okay? Now, as these guys now have elevated receptors, that causes them to produce even higher levels of estradiol, which then causes the anterior pituitary to, instead of having a negative feedback, have a positive feedback. And you have high levels of FSH, LH because the estradiol is so high. Because these 10 guys are also producing, let's say, 5,000 estrogen. Okay, as you get bigger. And that's why you have this switch from negative feedback to positive feedback. It allows us to weed out the weak ones. Okay? Does that make sense? Okay, great. Good. Now, here's our next question. We're making great time because we are going to finish up with these questions. Now, this next question we ran across was pertaining to also an endo-repro question, right? Was, well, what happens if you damage the adrenal cortex and you remove it bilaterally? What does the adrenal cortex release? Anyone? The outermost layers. There's only one hormone here. What is it? Yes, aldosterone. Perfect. Aldosterone is our guy. Okay. So aldosterone is what they're talking about. Okay. So they're saying now you damage it. What is most likely to now be present when you have a low levels of aldosterone? That's essentially what they're asking. They have all this mumbo jumbo stuff that's not even important. This is important, and the actual question stem is important. Everything else is just extra crap. Okay. Now, low levels of aldosterone. What happens? Well, aldosterone causes a variety of things to happen. Okay. One in particular, what aldosterone ends up doing is it causes you to increase your extracellular fluid. Okay. Increase your extracellular fluid as well as decrease your potassium. Now, how does it increase your extracellular fluid? Can someone tell me? How does it do it? How does aldosterone increase it? Yes, sodium reabsorption. Perfect. Sodium gets reabsorbed. Great. Sodium gets reabsorbed. And as a result, we increase water reabsorption. So then we increase extracellular fluid and blood pressure. Now, here's the next question. Because we don't have this anymore. So that means we have a decrease in aldosterone. That means we have a decrease in extracellular fluid. That means we have a decrease or an increase in potassium because we decreased the secretion. This went down. Now, when you have decreased blood volume, what does that do to things like renin? Perfect. It increases it. That's exactly what happens, which is why that was the answer to that question. Okay. That's why elevated renin is the answer. All right. Now, here's our next question. This is a throwback to your cardio, right? They're giving you these leads, V1, V, and AVL, and they're asking you which one of these is most likely damaged. Because we need to get to the area, the artery that supplies this tissue that got damaged. Okay? So for you to do that, you have to remember this guy. Now, there's different areas that have to do with different things. Some people just remember this image. And I get it. You like to do that, and it's easier to do an image and remember it. But let me reason it for you. Okay. Can you guys see my face? Let me stop sharing. Okay, you guys see me, right? My face? Let me reason this for you. Okay. It's very easy when you think of it. Now, you have three main leads. You got 1, 2, and 3. Okay. 1 goes like this from right to left. Okay. 2 goes down this way. Okay. Goes down. And 3 does the same. So you have this kind of triangle formation. Okay. Now, my question is this. If you have an infarct, if they say there's a damage in lead 1, this lead, that means the actual left side of the heart because it's pointing to the left side. Okay. That's why that shows up that way. Versus this lead that goes down, this is more gored towards the inferior portions of the heart because it's going down on the heart. So that's when you start thinking, oh, maybe this is like the right coronary artery and its corresponding parts. Okay. And then finally, when you look at AVL, because I'm just focusing on this question right now, but if you look at AVL, AVL points also to the left. which is why that's also part of it. Now, when you look at V1 through V6, it spans like this on the chest. Okay, so V1, V2 is in the center. So what part of the heart do you think is affected? The septum. Perfect. Because you gotta think, I'm a giant heart. You're no longer a human body, right? You're a giant heart. If you're a giant heart, right here in the center would be the septum. Right? And as you go further away from the septum, you now end up on the lateral portions of the heart. That's why V6 is the lateral portions of the heart. Okay? And that's how it's broken down. So you can remember it if you want to. I'm cool with it. However you want to. I just reason through it because it's easier for me to do that. Okay. And as you see, that's exactly how this presents. V5, V6 is the lateral portions. 1 in AVL is portions of the oh yeah, the lateral as well, but V5 and V6, here we go. I circled the wrong one, but that's also lateral. Okay, but it's more anterior than the lateral circumflex, but you can see it's still the same lateral portions. All right, now that's why you end up being the left coronary artery, because that is what supplies those areas of the heart. Now, next question. We looked at this question, and in this question, it's basically asking you which of the following hormones is affected? Okay, well, we have inhibition of this enzyme. So now it's asking you which of these is affected if you inhibit this enzyme. That's what the question is asking. Right? You don't need to know that investigator regulation of adrenal hormone synthesis in rats, serum concentration, different hormones, all that you don't need to know. So what does 11 beta hydroxylase do? Can anyone tell me what 11 beta hydroxylase does? What does it do? Eleven beta hydroxylase. This is in your adrenal glands. Okay. So the main thing that this guy does, yes, makes all. So it's mainly, yes, aldosterone and cortisol. Perfect, perfect. Love it. So it's making aldosterone and cortisol. Now, which one of these is affected if we have decrease of these? The answer ends up being epinephrine, because epinephrine has a really close correlation with cortisol. Cortisol stimulates the production of epinephrine via this enzyme, phenethylenolamine N-methyltransferase. Okay, and as a result, you form epinephrine. Okay, good. Now, here's our next question. Here is asking you, they gave dextrose, right? And it measures the intracellular fructose concentration. So this is dextrose is sugar. Okay. And they're basically asking you, where are you going to see the highest concentration of fructose? Where are you going to see it? So sucrose or glucose to fructose only happens in only a small portion of organs. And to make it easy, the reproductive organs. Okay, so here in this, we can see we have the formation of fructose. Okay, this here, we're forming this in their general idea of things. Now, whenever you have a lack of it, like I said, reproductive organs are the guys that have an issue with forming this, right? Because they take the sorbitol, right, and they change it into fructose. And because of that, you don't have a buildup of sorbitol. Okay. Some people say the mnemonic lose, and that works out, but reproductive organs really works for me. Ovaries, seminiferous vesicles, as well as the liver, because the liver does everything metabolically. Okay. And it's because it has this enzyme, sorbitol dehydrogenase. All right. Any questions on that? How do you? Oh, no worries. You don't have to add those. I appreciate it though. And yes, just perfect. Reproductive organs. Those are the organs that are most likely to have that aldose dehydrogenase to form the fructose. So that's why those guys are like that. Okay. All right, so let's keep going because I don't want to take you guys' time too much because you have stuff you have to study on your own as well. Okay. So now this is the second to last question, right? So in this question, they're essentially asking you, here's a cardiac examination of an S3 gallop. Does anyone know what an S3 gallop means? What does an S3 gallop mean? S3 gallop. Slow closure of the pulmonic valve. So S3 gallop, essentially this means just that you have high volume of blood. In the ventricles. Okay, so that's what that means, right? You have a lot of blood that's pooling inside the ventricle. It's also known as the slush, okay, because that's whenever you have water that ends up hitting water and you hear the slush sound whenever water hits water, because in the ventricles, they have so much fluid in them. So that's what the S3 is all about. But yes, it's usually due to heart failure. Perfect. Now, when you get that idea that this has to deal with volume overload, what type of adaptation does a heart do? This is something you guys should know. What type of adaptation? Yes, it thickens the wall, but how? How does it thicken the wall? Does it undergo concentric or does it undergo eccentric thickening? It undergoes eccentric thickening because you have so much volume. It's almost like a balloon, right? You pour a lot of fluid in there and it expands like an eccentric, okay? Another way they can say is sarcomeres in series, i.e. Okay? That's another way that they can say it. Versus concentric is when sarcomeres are parallel. Okay? So that's the big difference. And when you have sarcomeres parallel, you decrease the volume that can fit inside there. Okay? Versus increasing the volume in eccentric, which is what you see here. So the ventricular wall thickness decreases because it's expanded out. The cavity has increased because it's bigger. However, the diastolic and the pressure gradient is normal. The reason why is this. With the diastolic function, diastolic is how well the heart is able to relax. Okay? how well is the heart able to relax? So the heart is able to relax normally, so diastolic is not affected. However, in concentric, diastolic ends up increasing. Okay, because of it's not able to actually expand to accommodate the volume. You may also see the word compliance and how compliance decreases in this scenario. Okay, so that's why that ends up being that way. I put this in here just so you make sure you know this picture. This is a very big concept in cardio. They can strip so many different cardio ideas to this picture. Okay. Now, this is the last question, and this is a neuro question. Basically, this is asking you all this stuff, right? And then all of a sudden it says, which of the following sequelae is most likely to develop? And then I'm like, okay, so you wanted to know what's going to happen if a certain area is damaged. That's what you want to know. So what area is damaged? Okay, you read through it. Okay, cool. Got a hematoma on the occiput. Cool, whatever. Normal CT scan. All right, hyperdense lesion. So that happened. Oh, okay, occipital frontal lobe. So that's the area that's damaged. And you want to know what's going to happen if you damage this area. What is the patient going to present with? So for that, you have to know the different portions of the brain. And this is what I'm going to leave on. There are a lot of them. There are a lot of them. Yes. I'm not underplaying that. Do you have to know all of them? To some degree. Because with neuro, people love to stop blood supply and ask you what is the symptom they will present with, or give you symptoms and then tell you what blood supply is stopped. They love doing that. Okay, because people see all this and they're like, forget this. This is too much. I can't do this. Make it easy. Make it easy. So here, let me make it easy for you. Primary motor. So you got motor in the frontal lobe. Okay, as well as, once again, motor. Prefrontal cortex, personality. When you look at this, you can easily see there's only one of these that has personality. Okay, this here is a motor, and this is a motor as well. So when it comes to orbital frontal, you have to know that this is the most front portion of the frontal lobe. Okay, the most anterior portions of it. Now, you look at the parietal lobe. It's all sensory here in the parietal lobe. That's all it does is sensory stuff. Sensory, once again, sensory with vision. Okay. Now, temporal lobe. This is where you get more like the auditory. So hearing, listening, understanding, auditory, Wernicke's, once again, understanding, but pertaining to language. Right? You ask them, hey, can you open that door? And they're like, I say over there's a crab in the water and there's a seagull flying over the mountain. What? Like, do you understand what I'm telling you? I told you to close the door. You see, so that's what is understanding with listening and hearing. Visual cortex, all visual stuff. Okay. With you getting vision. Now, here they could throw out the aspect of that visual pathway, which I gave you a question on that daily question board. That's a really good way. Another way that they can ask about this stuff is that visual path. Okay. Good. That's all of them. I thank you for coming to this session. Yes, perfect. Occipital frontal lobe. is it. Yep, decision-making deficient. Yep, great. That's exactly what that is. Okay, so I thank you for coming. It was a very good session. I had really good turnout. It was really good. So moving forward, I'll still do the daily question board. I'll upload this recording for you guys, so you guys have access to it. The PowerPoint as well, I'll upload for you guys as well, so you'll have access to it. And moving forward, I'm thinking about doing more of these sessions. However, unfortunately, I'll be uploading it on so since you guys added yourself to my thing, I'll be able to send you an email, but I'll also upload it in the chat box. Oh, oh no. Yeah, the global health stuff. The global health stuff. Um, hey, I'm very happy to see you. I'm happy that things are moving along nicely. So I'll be uploading it on there, and I'll also be uploading it. I can also send you an email with it as well, with the link, and then I'll send you guys the PowerPoint, okay, for you guys to see. Now moving forward, I'm thinking about doing like maybe 2 more sessions for you guys. However, I won't be able to do them free. It'll be $20 a session. But what you can do is you can group together and you can actually cut that fee less. Because I don't care if there's multiple people watching it with one person signing in. I don't care. Right? I don't have any reasons to have any fault with that. But so I was thinking about doing 2 sessions with it. I'm not sure how many sessions because you guys have your exam on Wednesday, right? So there's only so many sessions I can pull in there. Are you guys still doing TA sessions? I think TA sessions are over for you guys, right? Because Med 3 is in their study period. Yeah. So you guys are pretty much on your own right now. So if you guys want to do more than 2, I'm open for it. I have no issues doing it. We can sit down, we can knock these guys out. I'll send a link inside the WhatsApp on how you can do that and purchase those and whatnot. I will say, and I'll give more information and details on it later about how the pricing will be. So you don't have to worry about remembering that stuff right now. You're gonna read it later. But yeah, I do agree. They fed you guys to the sharks, especially with all the changes. Yeah, so it's just gonna be $20 for whoever signs up, right? So I don't care if that one person has 4 other people who's watching the same feed. I don't care. Now, there's only a set amount of people I'm allowed into the visit, though. There's only 25 people I allow in. And the reason behind that is because if there's too many people in the actual call able to send messages, it gets very hectic. Okay. So I'm only allowing 25 people in, but if you have like a projector at your school, right, in those SGA rooms, you can actually project it on there because this is what some of my friends did because there was someone who did this before us. They would project it on the screen and then 3 people would sit there and watch it. That one projected on the screen. Okay. Or you could sit down with your friends somewhere and you can just have your up and you can have those people watching. However, I don't care. I'm trying to just help you guys out, but I have to tack a fee on it because I also, need to make some kind of living being here in the US, right? That's the only reason why I have some kind of fee on there. It's because I just need to be able to feed my family. So so yeah, but all that stuff will be included and I'll have that posted in the WhatsApp group. Okay? All right, guys. Um have a great rest of your day. I won't take up any more time of your time because you do have to study and prepare for your next task. Best of luck and you guys will be hearing from me soon. Okay? All right. Bye guys.